This is Professor Upfer, and this is the second part of our lecture on mental disorders, in which we'll look at anxiety disorders. Anxiety disorders cover two major categories, phobias and generalized anxiety. Let's see how well the Sally principle works for these. So, in a phobia is an intense, irrational fear that may focus on categories of objects or an event or a situation or a social setting. An example of a fear of specific objects come from specific phobias, where a person might say have a fear of snakes or a fear of substances like blood, or a fear of situations like being up high. These specific phobias are generally more prevalent in females than males. And there are some unusual phobias. So ailurophobia is a fear of cats. Agobophobia is a fear of pain. Anthropophobia is a fear of men. Monophobia is a fear of being alone. There's pyrophobia, a fear of fire. There's also a phobophobia, which is fear of fear itself. I kid you not, there really is such a thing. There is a phobia of leaving your home. That's known as agoraphobia. As a matter of fact, when the pandemic sort of washed through China, when people were forced to stay at home, many people developed an agoraphobia. Now, where do these phobias come from? Well, a lot of insight into where phobias come from came from studies of learning. Now, the development of phobias initially were explained from a very simple classical conditioning model. So the idea would be that why is somebody afraid of bees? Well, a bee in this view is a conditional stimulus. The unconditional stimulus might be, say, a bee sting. Since the sting is harmful, a person doesn't want to be stung, and when they see a bee before they get stung, then they associate the bee with the sting, and therefore they fear the bee as a harbinger of a sting. Very simple idea. There's a couple problems, though, for this simple classical conditioning model. One problem is that most people who are afraid of bees have no memory of any particular traumatic experience with bees. As a matter of fact, many people who are afraid of bees have never, ever been stung by a bee. If we were meeting in class, I'd ask everyone who among you are afraid of bees. Now, who among you has been stung by a bee? The results vary from year to year. In one year, the people who were afraid of bees was exactly the opposite group as the people who had been stung by a bee. So the connection between suffering a bee sting and being afraid of a bee doesn't hold up very well. In addition, people who have been stung by a bee and maybe found it very painful seldom have a phobia of bees. So this is not good for the simple classical conditioning model. In fact, more broadly, the prevalence of phobias bear little relation to real risks of harm. So here what I'm showing is the percentage of people who report being afraid or bothered slightly or not at all afraid of various objects or situations like snakes, being in high exposed places, mice, so spiders, dogs, driving a car, being in a crowd of people, and so on. And what's important about this is that most of you, all right, are highly unlikely to ever get bitten by a snake. You're much more likely to, say, be involved in a car accident. Yet, few people are afraid of cars, and many people are afraid of snakes. Again, that's not good for the classical conditioning theory. Modern learning theories, though, do a little bit better. So the idea here is that phobics have faulty expectancies about the conditional stimulus. So a bee phobic believes that bees are much more likely to sting than bees actually do. In addition, the appraisal of the unconditional stimulus is inflated. So a bee phobic believes that the harm done by a bee sting is much greater than it actually is. Now you put those two together. That a person thinks that a bee is almost guaranteed to sting you, and if they sting you, then it's really going to hurt a lot, maybe do terrible damage. Who knows? Maybe you're allergic and you don't even know it. All right. Well, now you've got a bee phobia. All right. This isn't connected to the actual experience of bees. It's connected to your actual ideas about bees and bee stings. Now, how do you treat these specific phobias? Well, again, modern learning theories provide a way forward. So the treatment for specific phobias typically involve a combination of things. One is systematic desensitization. So what you do is you place a patient under an extinction schedule. So if, for example, I wanted a dog to stop drooling every time I rang a bell, what I'd do is I'd ring the bell, the dog would get no food. I'd ring the bell, the dog would get no food. I'd ring the bell, the dog would get no food, and so on until the dog stopped drooling when I rang the bell. It's the same idea with something like bee phobia. You present the bee, but you don't get stung. You present the bee, but you don't get stung. You present the bee, but you don't get stung, until finally you realize, oh, the bee isn't going to sting you. That's the basic idea. All right. The other is to have relaxation training, construction of a fear hierarchy, and graded priming. The way this would work would go something like this. Let's suppose that you think that you're afraid of spiders. Okay, so suppose you're maybe afraid of spiders. Now, I want you to imagine the following situations and tell me where in your fear hierarchy this might go. Imagine for a minute that there is I said a cage, like an aquarium, with a spider inside, but the aquarium is covered with a blanket, so you can't see the spider inside. And I were to set the aquarium right next to your computer. Think about how scary that might be. What if I were to take the cover off the aquarium so now you can see the tarantula? What if I were to take the cover off? What about if I took the spider out and I put her on the table, but it's a very long way away from you? Or maybe right next to your hand. Or maybe right on your hand. Okay, you probably have some idea about which of these is going to be the most anxiety-provoking. Now, rather than just presenting the spider and in any sort of random way and not pairing it with a spider bite, that's not super useful, although it would be under an extinction schedule, and so it'd be somewhat useful. In the second systematic desensitization, I create this hierarchy, and what I do is I lead you through from the mildest to the most anxiety-provoking element, and we engage in relaxation training. So what would happen is maybe just seeing the spider in the aquarium with the blanket off, maybe that was something kind of mild for you. And we just sit there and you'd take a breath and you'd relax, and we work on getting your heart so that it's beating normal, your breath is normal, everything is normal. You're not acting or behaving or feeling in any way that's less uncomfortable with the spider than without the spider. Then we'd go to the next element in the hierarchy, and the next element, and the next element, until you can sit with the spider on your hand, no more anxious or breathing hard or heart racing than if the spider were not on your hand. That's systematic desensitization by means of relaxation training, construction of a fear hierarchy, and graded priming. Another method is modeling. So modeling just would involve maybe you would see another person going through this fear hierarchy, and the person doesn't get bit by the spider. Now, is this effective? I'll tell you first an anecdote. I had a student who was a graduate student who was interested in primatology. She really, really wanted to work with monkeys, and she had an opportunity to work with monkeys on an island off Puerto Rico, San Cabo. But San Cabo happens to be filled with snakes, and she was petrified of snakes. So she went through systematic desensitization. Her results were that she went through everything that I just talked about, but with snakes, until she was no longer freaked out and could actually hold a snake in her hand, put it behind her neck. She was fine with snakes by the end of therapy. That's just one case, right? How about more broadly? Well, generally what you find is that each treatment is effective, either systematic desensitization or modeling. New problems typically don't arise. Close to 75% of people with specific phobias improve with desensitization therapy. In fact, in one kind of very extreme systematic desensitization called flooding, you're actually given a bunch of images, say of a snake or a rat or a spider, again and again and again, and you're just taught to sort of relax after getting flooded with these images. In one of these studies, rat flooding induced 70% of rat phobes to pick up a rat, compared to 15% of rat phobes who were flooded with neutral images. So it does seem like using the insights from ordinary modern learning theory allows us to treat specific phobias rather effectively. What about social phobias? So social phobias involve either a fear of failing or being embarrassed in public. It might involve stage fright, so a fear of public speaking. I had a colleague who was a professor at Ohio State who had stage fright. He told me that he threw up before every class for almost 30 years. He never went through therapy, and I was stunned. So this is something that a person really could harm your life quite a bit. There's also a fear of crowds or a fear of strangers. It might involve a fear of meeting new people or eating in public. People with social phobias often don't want to eat around other people. It's sort of an intimate act, and they feel like they might be embarrassed having somebody watch them eating. I don't know why, but that's how they feel. Now, these, again, are considered phobic only if the fears interfere with normal behavior. So my professor friend, who was still able to make it into class, probably wouldn't be given a full diagnosis of a social phobia, although he would probably have benefited from some help. Social phobias, interestingly enough, occur about equally often in men and women. Now, the treatment of social phobias is, again, very similar to that of specific phobias. The treatment involves doing what you fear. That's an important idea. It underpins a lot of treatment for anxiety disorders, that you do the thing that you fear. So maybe you're afraid to meet new people, so you meet new people in social skills training workshops. There are these things all over the country called Toastmasters, where small groups of people get together and they might practice small talk or impromptu speeches or whatever, and get feedback in a gentle way, and it's in a supportive environment. This is widely used in the treatment of social phobias. Again, what you typically find is that just doing what you fear or just getting the social skills training alone is insufficient. But if you do what you fear and you get the training, then you can see that the conditional stimulus, other people, are not predictive of the unconditional stimulus, humiliation. So in this lecture, what we've seen is that rather than seeing phobias as a random, crazy fear, psychologists made advances in understanding phobias using principles from ordinary cognitive psychology. And advances in treating phobias also came about from applying ordinary principles of cognition. We'll use this idea to look at depression in the next episode.